Good evening, everyone. We welcome you all to Ortho TV in association with UTTARANCHAL Orthopaedic Association. To introduce today's speaker and topic, I hand over to our convener, Dr. A.K. Sirohi.
Thank you, Dr. Neeraj. Respected seniors and dear friends, greetings from Devbhoomi, Uttarakhand. On behalf of Uttaranchal Orthopaedic Association, we welcome you all in this 12th webinar of Uttaranchal Orthopaedic Association. Friends, we are doing weekly academic webinars on different subjects of orthopedics with top speakers and panelists from the country. Today we have with us Professor Anil Jain, who is an international authority on spinal tuberculosis, and he will be discussing threadbare the present status of management of spinal tuberculosis. We welcome you, sir. We have with us two renowned figures from the oldest living city of world, Varanasi. We have with us Professor Shyam Saraf and Professor Amit Rastogi with us. We welcome both of you, sir.
Thank you.
We have with us Professor Puneet Gupta from Dehradun, Uttarakhand. He is a renowned spinal surgeon from Dehradun, Uttarakhand. We welcome you, sir.
Thank you very much, sir.
We have with us President of Uttaranchal Orthopaedic Association, Dr. Inder Mohan Singhal. Welcome, Dr. Singhal, sir. We have with us our dynamic honorary secretary of Uttaranchal Orthopaedic Association, Dr. Puneet Gupta from Haldwani. Welcome, Dr. Puneet. I welcome our Ortho TV team. Dr. Neeraj Bijlani is with us. We are thankful to him, and Dr. Ashok Shyam, who are instrumental in broadcasting these webinars to all of you. Thank you, Dr. Neeraj. Now I would request our President, Dr. I.M. Singhal, for a formal welcome address on behalf of Uttaranchal Orthopaedic Association. Dr. Singhal, sir.
Thank you, Dr. Sirohi, sir. First of all, it is a matter of pride कि Dr. Anil Jain साहब, Dr. Saraf साहब, Dr. Rastogi साहब, Dr. Puneet Gupta, आप सब आज यहाँ हैं इस प्लेटफॉर्म पे. आप सबका देवभूमि में बहुत-बहुत स्वागत है. And we're really waiting for some enlightening tips and tricks about the spinal tuberculosis. So it is very comprehensive, very complicated, so very common. But still, I think we need to learn much more about it in the presentation. How do that create? Just specifically, I will request Dr. Anil Jain, because when to convert from conservative, that is a very silver line. When to convert our line of alignment from conservative to operating. So we want a bit elaboration to this. Welcome everybody. And hand over to Dr. Puneet to continue further. Our secretary. Dr. Puneet.
Thank you, Dr. Singhal. We will be introducing our speaker for the day, Professor Anil Kumar. He is a well-known spinal surgeon. We all know Professor Anil Jain is MS, FAMS, FRCS. Is my screen visible, sir?
Yeah.
Yes.
Professor Anil Jain is MS, FAMS, FRCS, England, and is presently working as Principal, University College of Medical Sciences, Delhi, and Dean of Faculty of Medical Sciences, University of Delhi. He is a eminent spine surgeon. He has been trained for spinal surgery at Harlowwood Hospital and Queen's Medical Centre, UK, and Royal Hospital for Sick Children, Edinburgh, Scotland. He is also the visiting professor with the Tamil Nadu Dr. MGR Medical University. He has got many awards, orations to his credit. The prominent ones, Sir Gangaram Oration 2019, Dr. Mukhopadhyay Oration, Silver Jubilee Oration, Kini Memorial Oration.
डॉक्टर सिरोही
Yes,
सर,
yes.
आपकी स्क्रीन विजिबल नहीं हो रही, आप प्रेजेंटेशन में?
स्क्रीन नहीं दिख रही है?
नहीं सर।
ओके,
हमें तो दिख
present.
रही है।
हाँ डॉक्टर सिरोही, यू आर विजिबल।
नहीं,
Screen is visible or not?
You are
screen is
visible.
not visible.
Screen is not visible.
Screen is not
It
visible.
is visible. I can see you.
No, screen.
No, you haven't shared.
No, your screen is not. It's only you are seeing.
Okay. Now? Is the screen visible now?
No.
So how is it? I am sharing it. Now is it visible?
No. सर आप तो दिख रहे हैं, आपकी स्क्रीन भी नहीं दिख रही।
Okay. Now?
Yes, now it should be.
Is it visible? Now is it visible?
Going to start, sir. It's going to start.
अभी शेयरिंग शुरू हुई है।
Okay.
अभी है।
So I have. Is it visible?
हाँ स्क्रीन आ रही है,
But it is not visible to me.
प्रेजेंटेशन नहीं है। हाँ प्रेजेंटेशन चालू करिए।
The screen is not visible to me. Is it visible now?
हाँ आप दिख रहे हैं सर,
Yes.
विजिबल है, आप विजिबल है सर।
Full screen.
Okay.
आ गया।
Okay.
Fine.
Professor Anil Kumar, who is MS, FAMS, FRCS, presently working as Principal, University College of Medical Sciences, Delhi, and Dean of Faculty of Medical Sciences, University of Delhi. He is a very eminent spine surgeon. He has been trained for spinal surgery at Harlow Hospital and Queen's Medical Centre, Nottingham, and Royal Hospital for Sick Children, Scotland. He is the visiting professor with the Tamil Nadu MGR Medical University. He has got many awards, orations to his credit. Dr. Sir Gangaram Oration 2019, Dr. B. Mukhopadhyay Oration of Bihar Orthopaedic Association 2009, Silver Jubilee Lecture Award, IOA Memorial, Kini Memorial Oration, IOA, Professor O.P. Sharma Oration, IOA 2009. He has published 142 papers in index journals with H32. He has a unique distinction of publishing most number of research papers on spinal tuberculosis in the world. He is listed amongst 2% researchers in orthopedics in India. He framed the first bone and joint tuberculosis guidelines for the government of India. He is past president of IOA. He was president IOA in 2014. He is editor-in-chief of Indian Spine Journal, ex-editor Indian Journal of Orthopaedics, ex-deputy editor JBJS America, and guest editor Core. He is chief editor of Turex Orthopedic Principles and Their Applications. We are honored, sir, to have amongst us with your vast experience. Welcome, sir. I would request Dr. Anil to please share his screen and come to present his presentation. Dr. Anil, sir.
Thanks, Dr. Sirohi. And as I was talking to him, I'm going to speak on current consensus in diagnosis and management, particularly some of the complications which we encountered while dealing the spinal tuberculosis. Now, as it was communicated in the beginning, that these index TB guidelines was an initiative because there were no guidelines available for extrapulmonary tuberculosis. So although these guidelines as yet not I mean, they still need a lot of work to be done on it. But then finally, with every 15 subject disciplines active efforts, these index TB guidelines were released by Government of India, which has page 75 to 84 about the bone and joint tuberculosis. And as with all extrapulmonary tuberculosis, there were not many consensus papers and consensus evidence available in most of the questions. So hence, there was a big issue how to frame the guidelines. So, and I'm sure Dr. Saraf was part of the discussion while this was going on. So we decided to pose 200 questions in a different segment, spine and extraspinal to ourselves, as if we are sitting in our outpatient, and try to find the evidence-based answer to all those 200 questions. And out of those, that created a document of about 157 pages, print pages. So from that, we took out 8 pages guidelines. And these guidelines are available on Ministry of Health, Family Welfare's website. However, when this all document was ready, so it just came to my mind that why not add some basic knowledge about the subject, and hence the genesis of this book, which is an evidence-based management guide. Now, I think I would recommend that these 2 review articles published with a gap of 10 years, telling the current state of knowledge in 2010 in British Journal Bone Joint Surgery. And I think this article has almost 500 citations so far. And then in 10 years down the line, we revised this paper as another current concept review for Journal Bone Joint Surgery American, which is published in 2020. So I think these 2 articles becomes the current consensus basic document till 2020. And they are, I would recommend that they are a good read to my mind. Now coming to the issue proper, extrapulmonary tuberculosis from pulmonary tuberculosis are different on many aspects. But the most important is that extrapulmonary tuberculosis have less general symptom, hence the diagnosis is late. So diagnosis of extrapulmonary tuberculosis of all kind is a challenge. And second, bacteriologically, you cannot prove it. You have a difficulty in proving because it is a paucibacillary disease. So hence low bacteriological diagnosis and source detection. But then if you look at the history of evolution of diagnosis and management TB spine, the main landmark was introduction of ATD that has divided the whole era into a pre-chemotherapy era and a post-chemotherapy era. And now with the development in surgical facilities, better diagnostic imaging and pathological, and introduction of implant uses have changed the outcome of the treatment, and hence there is a constant progress in the goal of treatment of TB spine. In a pre-chemotherapy era, before ATD, it was almost death or severely crippled patients, while in a post-chemotherapy era, we started achieving good outcome after the effect of ATD, and the residual kyphosis and sequelae of paraplegia were the endpoints. But then in the gap, the various issues were addressed by a lot of workers worldwide, from diagnosis so that one can make an early diagnosis to prevent neural complication and deformity, ascertaining the diagnosis to establish an early diagnosis, healing, how long to treat, neural recovery and principle of treatment, that uncertainty was resolved, spinal deformity, prevention and correction, instrumentation and drug resistance. So these gaps in the knowledge were filled gradually, And as a result, the current goal of treatment is healing of lesion with endpoint minimal or no spinal deformity and minimal or no sequelae of neural deficit. That's the current goal of treatment. And let's see how far we are able to achieve. Now, we all of our generation have read that this is the X-ray finding. These are the X-ray findings, and these X-ray findings help us in making the radiological diagnosis obvious. And we were diagnosing on these cases. But then, by the time this all stage has reached, there is an obvious deformity and there is maybe a risk of neural deficit. So now, knowing fully well that this is an inflammatory disease, starting as inflammation, gradually ending into the herniation of disc into the diseased body and losing destruction of bone, fractured of the bone, losing the height and developing deformity and neural deficit, which at any point of time may be visible on plain X-rays with some certain finding. So if we use imaging well, then we are able to diagnose spinal tuberculosis early. Well, bone scan we don't use now, CT we still use, particularly for CT guided biopsy, but MRI is a gold standard for diagnosis of spinal tuberculosis. And recently PET has been included as evaluation of the treatment outcome. So a presumptive case has been decided, has been labeled in index guidelines, is a patient with persistent localized pain for 6 to 12 weeks or more with constitutional symptom with local tenderness. And if there are X-ray pointers, then these all patients should be evaluated with MRI. So now this X-ray is a pre-MRI. This is a very old patient of somewhere 87, 88 or 89 patient, 1989 patient. Now you could see there is a straightening of spine and we suspected here, or maybe reduction of the risk space, one suspect here. And if we are able to diagnose at this stage with imaging, then we should be able to diagnose the cases early. Now for a cervical spine, increase in prevertebral shadow is a good indicator. And these are the normal cervical prevertebral soft tissue shadow, which is almost 2/3 of the width of the body behind. And in front of C7 is less than C6. So keeping these two things in mind, we can diagnose, suspect all those cervical spine and cervicodorsal region without being visible on destruction of bone or deformity. If we suspect here, then we can diagnose and treat early. And I think if we take a few example here, this is C1, C2, and on this suspicion, and one could see a destruction of C1 arch could be diagnosed, and one could treat at this stage before a complication develops. Even for that matter, this X-ray, which I had shown, this is an X-ray of a pre-MRI era. And at this point of time, we, since the MRI was not there, and in 6 weeks time, patient developed classical finding of an spinal tuberculosis on plain X-rays. So now it is possible that here we suspect, here we investigate and treat so that this should not occur. Now D1, D2, just suspicion of this shadow, the suspicion of increase in this shadow, and one could see underlying bone on a CT scan or an MRI, one can ascertain the diagnosis. Now on an MRI, the diagnostic feature are contiguous vertebral body involvement, intact relative preservation of disc spaces. You could see all disc spaces are preserved, subligamentous extension, which is low signal in T1, bright in T2, and large pre and paravertebral abscesses. These are indicative of large prevertebral abscesses. Epidural involvement, one could see epidural is the diseased tissue is entered into the spinal canal. Vertebral intraosseous abscesses and septate paravertebral abscesses. So these 7 are the classical findings, and if these 7 findings are there, then we can diagnose, ascertain the diagnosis on MRI in almost 90% instances, and that is why probably this is one of the most cited paper of this MR finding of spinal tuberculosis. Now, if we see another example, suspected here in a symptomatic patient, there is a destruction of bone here, and we got an MRI, and you could see two bone involved, septate paravertebral shadow. But since these are not those findings which I have described a slide before, so we got a CT guided biopsy, and the diagnosis was ascertained. On the contrary, if you have a lesion like this, where you have a heterogeneous signal in some vertebrae while intervening other vertebrae are normal, then it gives an impression as if we are dealing with a marrow disorders. And here the differential diagnosis is myeloma, lymphoma. And that is why whenever there are no classical MR finding, we must make sure that we take tissue for diagnosis. There is no place for empiric treatment, because if this diagnosis is missed here, then we are likely to encounter and we start treating just on X-rays in a non-classical case, then we may miss sinister conditions like myeloma and lymphoma. However, other findings which an MRI, one could be a liquid collection or a dry lesion, that also can be ascertained on MRI. So the nutshell, diagnosis has to be ascertained, imaging, and if by imaging we are not able to get it, then one must get a tissue diagnosis, whether we take it open or percutaneous. So, and this tissue must be submitted for microbiological and molecular diagnosis and histological diagnosis. Any tissue, pus, bony tissue, soft tissues, granulation tissue is good enough, whatever is available. But however, if all three are available in an open case, then all three must be submitted for lab diagnosis. Tissue could be obtained by CT guided biopsy or surgical debrima or aspiration of cold abscesses, and all tissue must be submitted in an adequate volume to the laboratory in a leak-proof container without a preservative. Sample should be transported to laboratory immediately and be processed as soon as possible. However, if not, you are not able to send to the laboratory same day, then preserve it in the refrigerator between 2 to 6 degrees Celsius temperature, and the tissue must be submitted for all. Now, this is the hierarchy of diagnosis for spinal or osteoarticular tuberculosis. On the top, demonstration of organism by culture is the gold standard. But in epocybacillary disease, the chances of demonstrating an organism varies between 30 to 50% lab to lab. However, now the molecular methods, gene experts, line probe assay have occupied the second place after the culture, and it's now chances of demonstrating mycobacterium genome is almost 90%. This was not there, this evidence was not there when index TB guidelines were prepared. However, after that, we took 2 studies to conclude that AFB smear 10 to 30%, and histological diagnosis not 100%, 60 to 90%. 60% are consistent, where caseating necrosis is granuloma is demonstrated or is seen, or a Langerhans cells are seen. However, it is suggestive if epithelioid cells and non-caseating granulomas are seen, and in that case, the decision, it is suggestive only, and interpretation can be taken only along with the history and X-rays and other imaging findings. So all 4 put together are to be used for diagnosis. Radiological diagnosis, clinical suspicion, and therapeutic response, they come very low in the hierarchy of diagnosis. However, some classical cases on imaging could be treated by without taking a tissue. So, since this data was not available, so we took this study, and now this study is published in Indian Journal of Orthopaedics this year itself, and you can read it. In this, 65 fresh cases, 12 suspected drug resistance cases were taken. AFB smear demonstrated organism in this series in 47%, AFB smear and culture in 69%, AFB smear, culture and histology in 93%, and when the molecular methods were added, then 100%. So putting test to all 4, there is a chance that in 100% instances, we will be able to make a diagnosis, ascertain the diagnosis of tuberculosis. While drug resistance cases, I think the chances of demonstrating organism on smear and culture are very low. One can ascertain diagnosis of tuberculosis on histology, and gene experts and LPA, there are chance that we should be able to demonstrate drug resistance against rifampicin and INH in more number of patients. So molecular method, diagnostic accuracy is 90% for tuberculosis. Primary drug resistance, one drug or more, is emerging 5 to 6%. And in a presumptive drug resistance cases, if culture negative, it helps in demonstrating the drug resistance. Then next we took 10 drug resistance by a molecular method. And again, we took 60 sample. And now this was a worrisome that when we got the testing done, we could find that out of 52 primary spinal TB cases, 13 cases demonstrated one or other drug resistance, out of which 3 were MDR. So this is a real dangerous sequence information which we have, and almost 11 of 60 have INH resistance. So one can imagine almost 18% to 19% these patients have INH resistance. And that is why the regimen now it's being modified to give 3 drugs as a maintenance part, rifampicin, INH, and ethambutol. And this I have already communicated that in a suspected drug resistance, chances of demonstrating drug resistance when culture is negative is there with the molecular method testing. This is one example, cervical spine tuberculosis, multiple bone destroyed, but patient no spinal deformity, no neural deficit, and aspirate demonstrated INH resistance. Another example here, the dorsal spine, dorsal lumbar spine, this was treated for deformity correction. And here, one of the method on genomic or molecular method, one could demonstrate that there is no drug resistance. However, diagnosis is certain on histology. I think this is one of the best example. One could see here, this lesion, no X-ray finding, no CT finding, no MRI finding are classical for TB. So what we did is that we put a needle here and took the tissue, and this tissue, this is the tissue, and this demonstrated by genomic or molecular method drug resistance to rifampicin and INH, and that to high level INH resistance. Smear for AFP was negative, liquid culture negative, and cytology was consistent for TB. So we were able to ascertain the diagnosis for TB. At the same time, we were able to demonstrate the drug resistance. So the message is imaging or tissue diagnosis, whatever, diagnosis must be ascertained in inflammatory stage before spinal deformity or neural complication appears. Now, coming to the treatment. Well, if you feel like I can take a few questions as far as diagnosis here, as was told by Dr. Sirohi, and then we can move on to the treatment.
The panelists are requested to have a healthy discussion on the diagnosis part. Anything not clear?
Dr. Jain, can I ask you a question? Dr.
Yeah,
Jain?
yeah, sure, please.
You said the PET scan has a role in the tuberculosis spine. So what role it has got in the diagnosis?
I think, no, it has no role in diagnosis. I made it very clear at that point of time, probably in the evaluation of healing. So I'll be talking about that in a few minutes in the subsequent slides, but not in the diagnosis. Absolutely, PET scan has no place for diagnosis.
Yes.
It is as non-specific as bone scan.
Right, right. Another interesting thing is the earlier days, we were taught, okay, diminution in the disc space on the plain X-ray is one of the radiological sign of the tuberculosis of the spine. But that time the MRI was not there, all right? And in your paper, it says one of the very good paper of yours with the MRI findings. And in this lecture, you said that the disc space is preserved when you say on MRI.
Yes.
So when do we see the diminution of this space in MRI?
No, I think what the message was that in X-ray, what we see is the bone. And when disc starts ballooning into the disease inflamed vertebral body, then these two bones come closer. And that is what is seen on X-rays as a reduced disc space. But actually, in good number of cases, good percentage of cases, this disc maintained its shape for quite some time after getting bulged into the diseased vertebral body. However, when this disease is far advanced and far exudative, then this disc now gets into the granulation tissue and the destroyed vertebral body, then it loses its identity. So, if you see an MRI, you may find that two of the discs are visible and one or two discs at the apex have lost its identity. So, in due course of time, when the bone is losing height and destruction is long standing, then it loses its shape, as well as because it is now mixed with the diseased tissue. But to begin with, in the inflammatory stage, it just keeps on herniating, bulging into the weakened vertebral bone as a result of inflammation. And that is what is seen, a preserved disc height on MRI, but on the plain X-rays, because bones are coming closer, it is seen as a reduced disc space. So that is the disc space. Here I am talking about disc per se.
Yes, Dr. Amit.
So Jain sir.
Yeah.
Sometimes very nice that we need to get a tissue diagnosis, especially for spinal tuberculosis. Many times when you get a picture in the MRI and which is not absolutely classical for tuberculosis, but you have a very strong clinical suspicion for of tuberculosis, and the reports also say that suggestive of tuberculosis, and the area which is being imaged is not amenable to, let's say, a CT guided biopsy or like sacrum S1 area. So how do we proceed in that kind of situation?
The what message I want to give, that we must make every effort to make a diagnosis. Correct. So that we are able to treat effectively. That is the point one. And two, almost 70 to 80 to 90% instances, the presence of classical MRI finding should be able to give us a confident diagnosis. And if our MRI finding are not characteristic, then we must make every effort to take tissue diagnosis, so that we are, because all those patients where the MRI finding are not classical, then there are more chances of missing some sinister. And I've shown you the example of S1 disease, that that was not a classical for anything. And then when we took a CT guided biopsy, we could not only ascertain the diagnosis, but at the same time, we were able to demonstrate the drug resistance as well. So the bottom line is that our diagnosis must be confident in all instances. As you said, you have taken a tissue, and if on a tissue you are not able to demonstrate organism by smear and culture tuberculosis, we all know that laboratory to demonstrate a organism on culture, they are very few. And histology, we get a suggestive. Yes. But then we have a strong clinical suspicion, because I said that if it is a suggestive diagnosis, then you have to take a decision based on clinical and imaging picture in collaboration with a histological finding in a suggestive case to start ATV, to treat as tuberculosis. But blanketly, when you have nothing, patient is painful and some finding, then blanketly one should not continue on ATT and rely that something will happen.
Thank you.
Sir, I would also like
the
to ask
MRI
you,
which I had shown, where there are heterogeneous signal, that patient, I remember, had lost 15 kg weight in 3 months' time, and we were very sure that we are dealing with a myeloma. But when this tissue was taken, to our surprise, it was tuberculosis. So,
look like Mets.
Look, bilkul, actually. And the way the patient had lost weight, actually.
Sir, I just have one question.
yes.
Yeah, please.
Hello.
Yeah, please.
Nowadays, since it's very common that each and every patient comes with the MRI without getting even X-rays or those, And most of the time, the diagnosis to begin with is done on the basis of MRI. Is there any classical, like we had in the previous days, classical radiological features? Is there any MRI classical features which may be helpful in getting the differential diagnosis?
I think I would like to, I'm so happy that you raised this question because one thing I would say that even if patient comes with an MRI, if we are starting treatment, ATT, then one must get a plain X-rays. It may not be required for that time for diagnosis and treatment, but it will be the most useful investigation 2 months after when you are evaluating the improvement or not an improvement. It is only the X-ray which is helpful in demonstrating that your patient is improving. MRI finding after 2 months, 3 months are going to be sinister because it is an inflammation that is going to increase with the bacterial death, and hence MRI finding will be increased involvement, and that is why in an immediate post-treatment lesion to be evaluated with plain X-rays, and that is why pre-treatment X-ray becomes the most important. Now, as you said about the MRI finding, I think that article of which I have quoted, those 7 findings, I think now that those 7 findings is accepted worldwide, and almost I have conducted 10 studies which has been published in various journals where I have taken inclusion besides other criteria on the MRI finding as well. So those MRI findings are now, I can confidently say, they are very reliable, because after that article, I think I might have used those findings to almost 1,000 patients. So those 7 constellation of those 7 MRI finding is now being taken as a the classical finding to suspect and diagnose spinal tuberculosis on MRI. And now it's being even accepted by radiologists, imaging experts.
Thank you, sir.
Sir, I would like to ask one question, sir.
Yeah.
Sir, in a case with MRI, no definite findings of inflammation, and a backache in a young boy about 17, 18 years, and Montauk's is highly positive. Can it be started ATT or not, sir?
I would not start ATT based on just presence of Montauk's. Maybe he might be having some other organ disease as tuberculosis, and for that Montauk's is positive, but not for spinal tuberculosis. If my MRI has showed me the symptomatic area, backache, spine, normal, then I would.
Oh, okay,
because
sir.
Montauk's is non-diagnostic.
Okay.
To my mind, Montauk's become most important if patient has a symptomatic lesion, patient has MRI finding, as I had shown those heterogeneous vertebral body, and Montauk's negative. Because then I'm worried, because Montauk's negative are observed in lymphomas, myelomas, all low immune conditions, or patient is HIV positive.
Okay.
Sir,
Thank you, sir.
sir, one question.
Please.
Sir, how frequently you are going for this ATT sensitivity, sir, or to check the drug resistance? Is it mandatory to go for sensitivity test?
I think it's a very good question, because we have to, although I have shown 2 studies where primary drug resistance to INH is shown, but should it be done, or can we say that should it be done always? Because, and should we leave some patients, or should we delay the treatment, starting the treatment when if these facilities are not there? I may not do in all cases drug sensitivity, but since I'm using Gene Expert and LPA, which is now government is providing at all district places, to ascertain the diagnosis, then in that case, at least rifampicin and INH testing is available to us. However, even in my own settings, if I have a classical case and I have a classical MRI finding, then I'm not asking for a testing, taking a sample and testing for drug sensitivity for all drugs. But if I have taken tissue for any reason to ascertain the diagnosis, then certainly must go to molecular gene expert and LPA. And that is why probably now government is planning to give gene experts and LPA facility to all district centers and as well as all dot centers. Their aim is so that these facilities are available. Because the advantage is that in a couple of days, LPA report is available and few hours gene experts report is available.
Okay, one more question, Dr. Sirohi, if you allow, that what is the cause of primary drug resistance? That is the patient who has never taken the ETT, but still we find that is a drug resistance for ETT. What is the behind? Why? Is it genetic or something?
Yeah, there are two theories being given for development of drug resistance. One is genetic mutation. Now, genetic mutation takes place in a very small, for some drugs, 1:10 the power of 6, 1:10 the power of 8, 1:10 the power of 12. So that is one genetic mutation. And the other is a improper treatment. And as a result of that, these sensitive organisms are.
No, he has not taken ATT anytime.
No, I'm coming to that. So that is why now it has been put as a primary drug resistance and acquired drug resistance. Now, primary drug resistance in a pulmonary TB is a very common feature because someone has a drug resistant tuberculosis and catches the pulmonary lesion from someone who is a drug resistant. But now more and more, as I've shown in this 13 of 52 as a primary drug resistance, although this paper is not yet published, but this kind of drug resistance probably tells that probably that patient had some initial infection by a drug resistant organism, and now these organisms are lying dormant in the body and now they have reactivated. So, but primary drug resistance is more worry than this acquired drug resistance.
Sir, sometimes we face problem like recently I faced one case of ankle. In that lady, sir, everything was negative except sir, counts was high and ESR was high. Her gene expert was negative. Even pus culture was negative for any aerobics. Other bacilli, sir. So in that situation, and the patient is having destruction of joint in radiologically. So in that situation, how can we label that this patient is case of tuberculosis or not?
What was histology?
Histology was also negative, sir.
I think to my mind, the issue is that we have to be very sure about submitting the tissue. We have to give a good representative tissue. Then only we can hope for to get diagnosis from laboratory. Our tissue must be a good tissue, good representative tissue. And maybe if percutaneous method doesn't work, have an open biopsy and take the tissue. And there should be no reason that histology should be negative if adequate sample, adequate tissue is being submitted. Shall I proceed?
Yes.
Okay. Now, mainstay of treatment is ATT. One thing is sure, but then you require surgery for surgery, type of surgery, surgery in quadriplegia, surgery in children, granulomas, or late onset paraplegia. It requires individualized approach. But one thing is sure that British Medical Research Council has clearly proved from the multi-center trials that it is a medical disease to be treated by ATT. And when we talk about ATT, I think I'll be talking about in these 5 subheads. One thing is that it is a multi-drug ATT. It is essential because in a disease focus, we have a varying multiple type of mycobacterium. Some mycobacterium are extracellular, rapidly dividing, while others are extracellular, slowly or intermittently dividing. And third is intracellular, intermittently dividing, acted upon by these drugs. And that is why a combination of all 4 drugs is the ATT. However, there will be some dormant bacilli, no drugs act against that, and we don't treat the dormant bacilli. So this is the combination, intensive phase for 2 months. And since intracellular organisms are taken care in 2 months' time, then we continue with rifampicin, INH, and ethambutol maintenance phase. And if you recall, initially it was rifampicin, INH, but with the demonstration of resistance against INH as a primary drug resistance, now the treatment is all 3 drug maintenance phase. Now, should we give alternate day or daily? I think it has to be given in a daily doses now, knowing fully well that even the intermittent regimen is scientific. Why? Because 20 years to eliminate tuberculosis, to take care of tuberculosis, it was thought that if we could give a DOT strategy, directly observed treatment strategy. And in that, it was planned that let the ATT be given in the presence of a healthcare worker. And that is why the intermittent regimen came, that it is possible to give ATT supervised thrice a week. Now, the rationale was that when mycobacterium are exposed to a minimum inhibitory concentration of ATT, they undergo suppression. Now, when the drug is withdrawn, they continue to remain under suppression for 24 to 36 hours. So that is why intermittent regimen were propagated. However, it improved compliance. But later on, what was found that if one dose missed, then there is a serious consequences, that risk of emergence of drug resistance. So now there is a unanimity, no more intermittent, it's all a daily doses regimen. 6 months, 9 months, 12 months, when it works for pulmonary, why not for bone? Bone is a possibility, and that was the debate. But the problem with this debate is that in bone and joint, we do not know what is the healed status, when to call it a healed status. Pulmonary TB, sputum negative, 4 months more, and that's it. But for bone and joint, we cannot ascertain when the lesion become bacteriologically sterile. So what we were in a research, we were following completion of regimen, 6 or 9 months, and with no recurrence for 2 years, that was the healed status. So define the duration of treatment. We conducted a study during the index TB guidelines, and it was very clear that there is a lack of consensus about what constitute the healed status in the literature. So second operational study after these guidelines were that let us try to define the endpoint of treatment, although this issue has not yet been resolved. So we took contrast MRI as beside the endpoint of treatment. And in this study, we did find that some of the lesions healed at 8 months, while others lesions did not heal at 8 months. So we continued 12 months, and some of them healed at 12 months, while others took longer time. So in this study, what we found that only 60% achieved healed status on MRI base at 12 months, while 90% at 18 months. So we concluded it is unscientific to stop ATT by fixed time schedule as prescribed 6 months, 9 months, 12 months, or whatever. So we resolved that we have to evaluate the lesion at 12 months to define whether lesion has healed or not healed. So, and this is one example. This is an active lesion, and one put MR diagnosis. And here this has shown resolution after treatment when the replacement of marrow edema by fat in T1 weighted image. And you could see here in T2 weighted and T1 weighted, this body has become bright. And that is what the fatty replacement. And this is what the healing on a comparison, that how the lesion has healed. But the problem with MRI that it continued to show persistent bone edema for quite some time. And since we know that MRI shows edema, means water. So is this persistent bone edema is because of disease or is because of healing? So that question came to our mind, that is this an active disease or continued inflammation? From the previous study, so we took another series with the PET scan. And there we found that PET scan was better able to demonstrate healing in 28 to 28 cases, while at that point of time, MRI was showing healed status in 52% cases only. So it means that persistent of bone edema was not supposed to be considered as an active disease. However, if there is a destruction of lesion, if there is a pus present, or then probably that's, but that's the other question, other point. But persistent of bone edema should not be taken as a active disease. But then again, we concluded that if we cannot treat, we have to treat till the healed status is demonstrated. And we cannot stop ATT by fixed time frame. So this issue is still not been adequately answered. And I'm sure a lot of researchers have to work for few more years to demonstrate, define the healed status in tuberculosis. Now, this is one example, 17-year female, no neural deficit. These are the MRI finding or classical MRI finding are present. And one could see at 1 year of ATT, radiologically, this shadow has resolved. And on MRI also, this lesion has healed, but was persistently showing a bone edema. So hence was when PET scan was done at 20 months, then we could stop ATT. So our resolve that probably persistent bone edema is to treat it with the persistent bone edema is little over treatment. And now this is another example, cervical spine disease, classical X-ray finding, classical MRI finding, treated by ATT, X-ray changes at 9 months time of a healed disease, MRI changes at 9 months of a healing disease, and PET scan at 10 months time, no active disease. So ATT was stopped at 10 months time. Another example, this X-ray I had shown in the beginning, and you could see the destruction of bone, those MRI finding. Here we took the tissue, CT guided, we have proven the diagnosis, we have proven that it is sensitive organism, and we treated with ATT standard regimen. And at 12 to 15 months time, we still had a healing of bone, but at the same time, some bone destruction was visible on X-rays. So we took an MRI again, and MRI shows intraosseous shadows, which on contrast enhancement shows intraosseous enhancement. So it was an intraosseous abscess. And that is why we took a CT guided biopsy again. And this CT guided biopsy shows histologically granulomatous lesion seen. So although this lesion has resolved, but still there was some activity of disease was present. So we had to treat this patient for another 3 months, and at 18 months, this ATT was stopped here. I would like to make it a point here that genomic study in a treated lesion is not a good idea, because presence of genome or gene expert and LPA just demonstrate presence of genome, and that genome could be of a dead bacteria as well. And that is why we took this lesion as active based on histologically granulomatous lesion seen, caseating granuloma seen, and that is why we took it as a still active lesion. Had it been only gene expert LPA positive, we may not have taken. And the best corollary to this is that Egyptian mummies, when the tissue was taken from some of the disease focus, then they demonstrated positivity for molecular testing. So standard ATT, 4 drugs for 2 months, 3 drugs for 10 months, daily doses, continue to monitor every day, every month for development, progression of neural deficit. Some patient require surgical intervention, take them for surgery as per indication. Total duration 12 months, extendable to 18 months on case-to-case basis in a sensitive disease. Now, ATT in children, again, an issue. I think these are the doses up to 25 kg in children. And these doses have to be followed, and these drugs are given in the weight band category. And that is what on every visit of the child to you, you must take weight of the child, and ATT doses need to be revised based on the weight band. Now coming to surgery, yes, drug therapy is mainstay. Surgery is done for complications, and the indications are neural deficit, cord compression, or instability, impending neural deficit. That may be in a global disease, pan-vertebral disease, where body and posterior complex is disease, or a long segment disease. Deformity correction in children. So these are, there would be some indication, and presumptive drug resistance and late onset paraplegia. So these complications, they require individualized approach. Now, TB spine with paraplegia, the question is, should we operate all, or should we do surgery for few? And this was the 60 cases evaluated prospectively. And we could find that just mere presence of canal encroachment does not mean surgery. If there is no other reason like neural deficit or any other reason, we should, presence of canal encroachment does not mean that we should operate. Liquid compression generally resolve on ATT alone and likely to recover if spine is stable. And you could see the example, this liquid pus has completely resolved on ATT. While mixed extradural collection by these findings will need early surgery, because here the compression maybe could be because of disc, or could be because of bony sequestra, or could be hard tissue which will not resolve on ATT. Cord edema alone will recover on ATT, while myelomalacia may not recover on ATT, and these patients, they need to be operated because it is correlated with the bad prognosis. Well, cord reduction in the cord volume may be found mild in almost all cases after treatment, while moderate to severe cord atrophy is found in a severe paraplegia or late onset paraplegia. And presence of syringomyelia is being found in some of these patients of late onset paraplegia. So patients respond on non-operative treatment are predominantly fluid collection in extradural space, relatively preserved cord size, and cord edema. And if these patients have no other indication like instability, like deformity, then these patients are likely to improve on ATT. And that is what is the essence of middle path regimen, that if you give ATT to 3 to 4 weeks, almost 25 to 30 to 40% they recover. And probably now with MRI, we can say it is these patients, they are likely to recover on ATT alone. Now, instrumentation, yes, now we can do safely because it makes very thin biofilm. Well, there was a lack of consensus, so we published this meta-analysis, and we defined the instrumented indication of instrumented stabilization. One is pan-vertebral lesion, where body as well as posterior complex is disease. And if we do not stabilize, then likely event could be a translation of proximal spine over other. And hence, this is an indication of instrumented stabilization. Well, grossly unstable spine, if long segment disease, you are decompressing, then you need to support the graft with instrumented stabilization. Or correction of kyphosis, such as severe kyphosis, if one is correcting, then you need to instrument. And TB of junctional area, because it is a junction of a fixed and mobile spine like cervicodorsal or dorsal lumbar, then it is better to instrument. And instrumentation could be anything, pedicle screw, hard shell, plate fixation, all works well if correct principle is used. Here we use the pedicle system, here we use the hard shell, and here even we combine both of them for certain specific situation. And here in cervical spine, only posterior was done and remaining was grafted. So you have to use the correct principle. And this is one example I am very keen to show, such a long segment disease. You could see here, this disease patient has neural deficit, and you could see the MRI, long segment disease, and you could see the CT, bone destruction here. So what we did, we used the hard shell so that we could preserve some of these healthy segment, and we have taken purchase against the intact healthy posterior complex. This is another example, 2 lesions, paraplegia matching with this upper lesion, and you could see unstable spine as well. So now you could imagine how long pedicle system we have to put in. So what we did is that we took a purchase in between here, and that is how the patient made a complete neural recovery. And this is the good use of instrumentation. Now here I'm going to show one complication in a child when they have a C1, C2 disease. So C1, C2 disease, if treated with ATT, and we have to take a flexion extension X-rays at 3 months or beyond and see that spine is stable or not. And there may be a situation that C1 is translating on C2 even after being adequately treated by ATT. And in that case, C1, C2 posterior fusion, Galli's fusion is to be done. And one could see this spine is completely stable in a flexion extension fill. Now coming to spinal deformity in the whole segment of spine, I think all issues are important. Which spinal deformity to be corrected? If we don't correct, what is the natural history of spinal deformity? And if we are planning to correct, what are the principles? And what happens to the deformity in children? These are the serious issues to be addressed. One thing is sure, that spinal deformity, if left at 60 degree or more and lesion has healed, then risk of late onset paraplegia is more. This deformity progresses while on treatment. So hence initial vertebral body loss is a predictor of a final kyphosis at completion of treatment. And third is that deformity correction surgery is simpler in active disease and easier with less complication than with the healed disease. So hence it is important that we should diagnose so that deformity should not develop. However, if deformity has developed, then they should be corrected in active stage of disease. And if they have to be corrected in active stage of disease, then question is how to do it. Now, this is the line diagram. There is always a retropulse tissue. So we cannot correct the deformity without opening the disease. And we have to do an anterior corpectomy in all cases. Now, when you correct the spinal deformity, the vertebral column lengthens, and hence the posterior column shortening is to be done. And when this all 2 things have been done, anterior corpectomy, posterior column shortening, then you need to do instrumented stabilization and anterior gap grafting and posterior gap fusion to be done sequentially and simultaneously. These are the broad principle of deformity correction. And you could see many examples where this deformity has been corrected surgically. And you could see this lumbar spine and the pedicle system is used. Such a small child, we corrected such a severe deformity. The spine is translating here and we corrected this deformity. Now, this case is very important. This patient came with such a severe lumbosacral deformity after taking ATT for 9 months. So surgically correction of such a severe rigid kyphosis is very difficult. So what we did, we gave a cephalocaudal traction, and you could see here with the cephalocaudal traction, this is corrected to quite an extent. And now we took it surgically all posteriorly, posterior column shortening is done, anterior debridement has been done. And when finally we corrected, it is significant correction is being seen at lumbosacral kyphosis. Another example, so you have to use the principle of deformity correction correctly. Now coming to drug resistance in spinal TB. Well, we know that it is known for pulmonary TB. It is easier to diagnose, but of late we have started suspecting for spinal TB as well. And the issues are which case to be suspected, how to establish drug resistance, and how to treat. These 3 questions we have attempted to answer in last 7-8 years. Now, if you have this kind of patients and you have started ATD, and after 9 months, you could see the lesion is almost the same. In fact, 1 vertebrae more is entered into the disease segment. So it means this lesion is not responding. So what is the clinician's concern? Is our diagnosis is not correct? Are we dealing with any other granulomatous disease? And if our diagnosis is right, Is it a paradoxical reaction or a drug resistance? So paradoxical reactions generally observed in those lesions which have initially improved, usually observed in first 3 months. During first 3 months, the patient gets a increase in symptom after showing some improvement. While suspected drug resistance, they fail to improve from or deteriorate on ATT, and no improvement until an effective second line ATT regimen is started. So in one of our study, we defined what is a suspected drug resistance, and suspected drug resistance are those who does not show healing 4 to 5 months of ATT. If a new lesion develops, or if a new abscess develops, or if a postoperative lesion shows a wound dehiscence, or a sinus develops, then these are the situations where we must take a tissue to a certain diagnosis by histology, smear, and PCR genotypic method. We need to ascertain the culture by culture sensitivity and genomic study as gene expert and line probe assay for rifampicin and rifampicin INH resistance, or a culture may give demonstrate resistance to any other drug as well. We must send this sample to 2 national accredited laboratory, and if there is a discrepant result, then we have to treat the worst case scenario. Now, these are the various definitions: single drug resistance, 2 or more drug resistance, rifampicin INH, that is multi-drug resistance, and XTR. And these patients will be labeled as after obtaining a culture and molecular method to demonstrate the drug resistance. Now, so there will be a situation that we have a case of suspected drug resistance, and when we have taken a tissue, histo is positive, culture or molecular method demonstrate drug resistance. So we have a proven drug resistance. However, if histology is positive for tuberculosis, but culture shows no growth and molecular methods are indeterminate, then we have to treat them as a clinical resistance for a MDR, rifampicin and INH resistance, because that is the most common drug resistance. I think this article in Indian Journal of Orthopaedics discusses the criteria to suspect drug resistance. Now, when you have diagnosed drug resistance, we have to know that these drugs to be used as drug resistance are less potent, more toxic, and expensive. They are used in higher number, 4 to 7 at times, may require hospitalization because drug-related complications may occur. But these are the few principles. Use a drug that has never been used always when treating the drug resistant. Never add one drug to filling regimen. I think I would like to stress this point, that it is now a common practice that you say, okay, it's not responding, just add moxifloxacin. I think that's a very wrong approach, because if patient has a proven drug resistance, then this moxifloxacin is a very important drug to treat a proven drug resistance cases. Preferably 5, but at least 4 new drugs to be given. If these all drugs to be given in single dose, no divided dose, no intermittent dose. And if you have got a culture sensitivity report, then no drug should be kept as reserve. It should be ensured that patient has taken that drug, and surgical treatment may be needed as an adjunct to debride the lesion to reduce the disease load. The counseling of patient is most important, because taking these drugs have more compliance issue, and patient is to be counseled not to stop treatment even if discomfort is present. These are the various regimen, individualized regimen, 6 drugs and more: aminoglycoside, kanamycin, amikacin for sure, any fluoroquinolone, any thiodomide, any 2 or more of following drugs like pyrazinamide, ethambutol, PAS or cycloserine. And these drugs have to be maintained for 6 months. Kanamycin can be stopped at 6 months and rest to be continued for 20 to 24 months, or as evaluated by MRI and PET scan. These are the various regimen prescribed by WHO. And you could see here where sensitivity is not available, even the regimen is described by WHO. So these are the regimen, and I would always recommend that when you are treating such case, then take a pulmonologist in part of your team. Prevention of drug resistance is the key. Ensure drug compliance at first instance, because acquired drug resistance, the most common cause, improper ATT regimen. And never add a single drug to failing regimen. That's the second. And I think this article is again in the Indian Journal of Orthopaedics, can be read for drug resistance tuberculosis. And now I will give you two examples. This is the TB spine D9 and D10. And you could see here that 8 months ATT lesion is almost the same. So we suspected at 8 months lesion is almost axial pictures are almost the same. So we did anterolateral decompression, taken enough tissues, submitted for all, but then as usual, pus culture negative, Bactec negative, FB smear negative. The only thing was that histology was positive, so our diagnosis was correct. So we treated with as a clinical drug resistance as MDR protocol, and on MDR protocol at 18 months, this lesion is showing healing. And one could see at 18 months MRI in T1 weighted image, this fat necrosis or fatty shadow of the vertebral body is an sure shot evidence of a healed lesion. And you could see an axial pictures as well. And we did PET scan also in this, which shows no evidence of metabolically active disease in this lesion elsewhere in the body. Now, this example is a patient from 3 era, when we had no idea about MDR. We were treating with some regimen on plain X-rays, and then ATT, some knowledge about the MDR came in the discussion, and today. So this is going to make my point, which I have talked so far, very clear. This patient reported to us in 2014 with backache, fever with constitutional symptom. At some hospital was diagnosed spot spine D10, D11, started on category 1 ATT, and correctly diagnosed by X-rays, correctly treated by ATT, 18 months ATT in 2009. Imagine, we were 12 years before, and this lesion has healed radiologically as we teach classically. Now, patient became symptomatic again at 14 months follow-up. By that time, MRI was available in Delhi. So that hospital got an MRI, and that shows a healed lesion, old lesion, and a new lesion in L3. So that time the standard practice was category 2, streptomycin was added, and AT started. 18 months full protocol, foot regimen was given, and at 18 months ATT was stopped. Now patient was continued symptomatic, so he went to some other doctor, and a month later got an MRI, and then he palpated a saw sepsis. So he aspirated the saw sepsis, drained the saw sepsis, but then the knowledge to submit for molecular tests were not available, and even the culture was not available at most of the places. So ATT was restarted. But by the time people were discussing the drug resistance, suspected drug resistance, so that very clinician started cycloserine and moxifloxacin besides rifampicin and INH and ethambutol, suspecting it to be MDR TB. Logic of regimen, God knows why these two were started, but MRI was performed 2 months down the line, which showed reduction of the lesion. Abscesses, short saw sepsis was not there, probably even after drainage. So whatever wisdom, all ATT were stopped except rifampicin INH was continued. And then patient continued to remain symptomatic. And July 14 and September 14, he kept on, he was advised multiple MRIs. At this time, patient reached us. So when patient reached us and we looked at this lesion, so we first, by the time we were already working on drug-resistant tuberculosis, so we put a needle, CT-guided biopsy, and a drop of pus came out, and that drop just gave this information that tuberculosis is definitely active, but no other information could be obtained. So we were in a dilemma, should we treat with the multi-drug resistance protocol? But at that time in 2014, we were not having this much knowledge also. So we continued on standard ATT, but then we kept on talking to this young girl that she will have to go retroperitoneal surgery to reach to L3 to reach to this lesion. And it took us convincing to the parents and family for a few months, and we went in by retroperitoneal approach, reached this vertebral body, and when we reached in, a clump, a mass of fibrous mass came out with a perimass pus collection, small pus, which was about the size of a lemon. And that was submitted for all investigation, and we started standard MDR protocol. That all diagnosis was ascertained, and that demonstrated, culture demonstrated rifampicin and INH resistance. So we were not having molecular test at that time. And patient was put on second line standard MDR protocol, and patient has achieved complete healed status. Now she's married and had children. Now, a last complication I will talk about in children. And I think at this point, I would certainly love to make it, because children bones are cartilaginous. And that is why this destruction is more complete. Bone vanishes in a shorter time. And you could see here, there is no trace of bone. There is no trace of bone. And that is why deformity is very severe. And you could see this example. This patient came to us at this stage, and he was carrying this X-ray. In 3 months old X-rays before this, when he came, and I'm sure had he been diagnosed here and treated here, probably this severe development of severe deformity could have been avoided. Now, and we need to understand that in children, deformity progresses with growth. Even after adequately being treated for TB, this deformity may progress with growth potential. And this is what, in spite of posterior spinal fusion of 1989, this deformity has progressed because some of the deformity in children progresses, and we know that 39% instances deformity progresses. And these are the various examples of deformity in children, and hence deformity is a serious concern in children. And these deformity need to be surgically corrected, and all efforts must be done to correct them by surgery and following adequate protocol for follow-up post-op during in such a small children. I'll give you this example. This came to us just before COVID. And this father was telling that in 6 months' time, this deformity has increased from here to here. So this is a progressive deformity even after adequately being treated by ATT. When we looked at his X-rays, we found that this was the X-ray patient had, this was the MRI patient had, and look at this MRI, such an extensive disease, and even the posterior complex disease. Body disease, posterior complex disease. And this patient is lucky that patient is not paraplegic. Probably this should have been surgically treated at first instance. And now we know it that this is a progressive kyphosis. Child has potential for few more years of growth. So this will progress further. And if this is going to come back to us with a late onset paraplegia. Another example, surgically treated, this paraplegia patient recovered completely on MRI. This all patient was carrying. Patient came to us at this stage with increasing kyphosis, cord changes, and there is small patch is coming on the spinal cord. So this is the late onset paraplegia and progressive kyphosis. So late onset paraplegia is a serious risk in growing children if this deformity is not halted. The growth of deformity is not halted, because late onset paraplegia is on an internal salient chronic insult to the spinal cord produces certain changes into the spinal cord. And this patient, these changes are permanent, hence they are not likely to recover. Very few instances, reactivation may be the cause of late onset paraplegia, and that is what we have to, these are the patients which has the reactivation are likely to show some neural recovery. Another cause of late onset symptomatology in a severe kyphosis is severe lumbar canal stenosis in such a severe lumbosacral kyphosis. Now, treatment of this lumbar canal stenosis is very difficult, is not as simple as we treat for a degenerative lumbar canal stenosis. Or other causes is ossification of ligamentum flavum secondary to healed kyphosis in a late presenting as a late onset paraplegia. So these all have to be evaluated. These cases undergo severe cord atrophy, unlikely to recover, and syringomyelia, which is unlikely to recover. And that is why late onset paraplegia is better prevented. However, if it occurs, it reaches us, then we have to look for reactivation of tuberculosis and treat by debridement, stabilization, and whatever as per the active disease. However, if it is because of cord stretching as internal salient, a true healed disease, then decompression and instability is to be done. And if there is an ossification of ligamentum flavum, then that pathology need to be adequately addressed. So these are the approaches. Internal salient, remove it. And if there is a late onset because of ossification of ligamentum flavum, then you have to address that pathology. But should this severe kyphosis cosmetic correction should be attempted? I think this should not be attempted. Well, although there are few reports are coming nowadays where dorsal and dorsal lumbar deformity are corrected in a healed spine, but I think this is a very complex surgery and it's not for commoners. Overall, prognosis of late onset paraplegia is good because excision of this internal salient is difficult and there are risks of neural deterioration because of handling of this spinal cord. And I will give you this example, such as severe cervicodorsal late onset paraplegia, dorsal spine late onset paraplegia, and where we corrected by transthoracic approach. And in spite of taking all precautions, this was the removal of internal salient, this patient developed some neural deterioration, a bad sore, although which recovered in due course of time. In direct internal kyphectomy by extrapleural anterolateral approach in a dorsal spine late onset paraplegia is an easier option than going to transthoracic, and as it's been done in this patient by us. The chances of complication in a late onset paraplegia, neural deterioration, dural tear or CSF fistula, besides the general complication. Hence, patient should be a party to the treatment. Patient, all discussion should take place before contemplating any surgery for late onset paraplegia with the family or with the patient. But at no point deformity should reach to this stage in any patient. As I said, patient to be part of discussion about treatment in late onset paraplegia. We should have discussion about indication of surgery, need for surgery, type of surgery, and likely complication and expected neural outcome. And this is one example. And I think this is the cervical, the upper dorsal spine, and that's how it's been done. So friends, I've talked about diagnosis in a presumptive case early before classical lesion, how to ascertain the diagnosis, hierarchy of diagnosis, in treatment, drug therapy, differences in adult children with deficit, without deficit, intervention, when, type of intervention, drug resistance, how to diagnose and treat TB spine in children, paraplegia with heel disease. I have not talked about granulomatous spinal TB. Thank you very much indeed for patient hearing. And if you have any queries, then I'll be too happy to answer questions.
Thank you, sir. Thank you, Professor Anil. Very long topic and dealt very aptly by you, sir. Really, master can do this only. And you have proved it by your great experience over the years and years. Thank you, sir. I would request Dr. Puneet, are there any questions from the Dr. Puneet?
Yes, sir.
Are there any questions from the audience?
There is no question from the audience.
So we can have a discussion, sir. Dr. Saraf, sir.
Dr. Jain, your regimen, that the 4 drugs for 2 months and the 3 drugs for maybe 10 months or 12 months, it all depends, is a very convincing one. But the different orthopedic surgeons in the country, all over the world, all of them have their own regimens. Can there be a consensus which can be followed by majority of us? What is the status of drug regimen right now?
I think this you have raised a very valid question, but I think this question, this problem will be addressed very gradually. It's going to be addressed because now it has become a notifiable disease, and 4 drugs and 3 drugs, these are now part of government protocols. So there is no difference in the drug regimen. And now, since it's being a notifiable disease, we almost all patients in those states where the drugs are only available in the DOT centers only, or tuberculosis centers only. But I would suggest that we should consistently follow the same protocol, because this addition of ethambutol to the maintenance phase is based on the demonstration of INH resistance, and that is why these 3 drugs have to be continued till the completion of regimen. And I don't see any reason why pyrazinamide should be continued beyond 4 months, because generally intracellular organisms are taken care by the pyrazinamide.
I have one more query on that. That in the drug-resistant cases, MDR TB, is it true that the WHO guideline says that the pyrazinamide should be continued throughout the period of treatment? It should not be stopped?
To my mind, there is a lot of new drugs are now being added, and there is a lot of new protocols are coming up by WHO. So I would always believe, and even after treating so many drug resistance, because I am getting almost 2 new patients a month. And in spite of treating all such a large number, I think this COVID has created discontinuity. But before COVID, almost 2 to 3 patients every month I was getting to plan the treatment for them. So now what I've done is that I have included one pulmonologist from National Institute of Tuberculosis. And now after debriding the lesions, ascertaining the resistance, I'm putting the treatment in consultation with them. And there are now new drugs are being added. So Bidaquine and all those other drugs. So maybe it is always a good idea to include a pulmonologist when you are treating a drug resistance case.
Sir, what is the role of braces and bed rest nowadays in the spinal tuberculosis?
I think one thing is sure, that bed rest, if your spine is stable, if spine is stable, 2 to 3 segment disease, and then probably there is no great advantage of putting the patients on bed rest. But if suppose it is a junctional area, then what we and we have an issue with the intelligence and compliance of the patient, then sometimes we do put these patients on bed rest. But braces, definitely I put them, because it is the mechanical stress and strain on the disease segment. At least it reminds the patient that patient has some tuberculosis of the spine, and definitely it is supportive to the spine. From the biomechanical insult to this weakened bone that can take place. So I always put braces, suitable braces, region-wise to all patients. And definitely, if patient is paraplegic, so he is going to remain on bed for certain length of time till the patient becomes regains the neurology, till patient is able to walk. And the best example, I think, which Dr. Saraf Saab and Dr. Amit would agree, because this was, we never realized till till I worked with Professor Tuli, that he used to put dorsal 1, C7, D1, D2 patients or D3 patients on a held halter without putting much weight, small weight, for a few weeks. And later on, we also saw so many patients that they show better recovery if we put them, because the stresses onto the spine, where a junction of mobile and flexible spine. And in tuberculosis, there is always a tendency to force diseased tissue and pus into the spinal canal because of dorsal and adding into the kyphosis. So it is a good idea if you find that lesion is extensive and lesion is long segment disease. For some time, one can put on rest, relative rest, I would say, mobilized with the supported brace.
Sir, what is the right time to do a PET CT after the completion, when you are thinking that we are going to stop it? How many months
I generally, I don't do PET CT in all cases. One, if I have got an 12 months MRI and I find that disease lesion has healed, T1 weighted fat necrosis has come, then that is good enough for me.
Okay.
Now, if there is a persistent activity and we have almost completed the regimen, then sometime we get a PET scan done. To my mind, the best indication of PET scan before stopping ATT is when you have put this stainless steel implant. And it is not very uncommon for a country like ours, where the implant, sometimes the cheaper hard shell is the only option available to instrument the spine in tuberculosis spine. And in that cases, probably PET scan is very useful. But then we will like to minimize the use of PET scan. So we ensure that clinically patient has improved, hematologically patient has improved, radiologically lesion has showing the signs of healing. Then once for all we do, and then stop.
Okay.
But not as a routine. Amit wants to say something.
This is another question, sir. This is not in relation to your previous question. A patient has, let's say, junctional tuberculosis at dorsolumbar junction. We have done an MRI and we have got classical findings of tuberculosis, and we started treating this patient without doing a tissue diagnosis. We started doing this treating this patient on ATT. When would you call the patient for follow-up the first time, and when would you label this patient as a probable presumptive drug-resistant case when he does not improve? So how long are you going to wait? Are you going to wait for 6 weeks, or 2 months, or 3 months? How long?
I think, see, when we start ATT, we generally like to get a hematological testing as per the standard protocol, LFT and all that, initially, frequently, and later on 1 month or 2 months. I would like to educate the patient for likely complication which may occur, and if he notices anything, then he has to report. First X-ray at 2 months, showing the difference in 2 X-rays. And if it shows some improvement in the form of mineralization or sharpening of trabecules or something, then I'm sure that I'm moving in the right direction. And by that time, patient will be symptomatically better.
Improved, yes.
Now, if patient is continuously maintaining improvement, then I'm okay with it, and I will not get anything else, continue to treat. However, if I find that a 2 months or 3 months patient is symptomatically is the same or worsening, or a new lesion comes, or an abscess comes, or post-operative patient wound dehiscence comes, or then probably at all things persistent, then at 5 to 6 months, 5 months, I'll get an MRI. And if I find some more findings, then that is the time, then we have to label as presumptive drug resistance. And why this 5 to 6 months? Because pulmonary TB says that if 3 to 4 months sputum conversion doesn't take place, it is a presumptive drug resistance. So we thought that since we are taking it on imaging, on X-ray and all those, so we have taken 4 to 5. Now, with the more and more molecular testing done for pulmonary, so they are revising their own things. So maybe but the bottom line is, I have shown that MRI example, that at 9 months, the lesion was same. And in fact, one vertebral body has been added to the lesion, and we have shown. And if some of you recall to RNTCP, for the first time, Indian Orthopaedic Association in 2006 Delhi conference, we had a 2-hour session where I kept 2 of my such patients, which I was thinking it to be a suspected drug resistance, and WHO guidelines, Government of India's guidelines, they were not supporting the treatment. So probably there, I called in that meeting, we called almost all top brasses of RNTCP for tuberculosis. And then after this session, they agreed, I think we have to address this question. So that's how the thinking started. But I'm sure there is nothing definite that 5 months or 6 months. But I'm sure if at 2 to 3 months or 4 months, because early 3 months, this could be paradoxical lesions, where you just don't require anything. You have to just convince the patient, give some good nutritious diet, and then some anti-inflammatory, and in 3 months' time, or NSAID, and 3 months' time, they start showing improvement. So if we, after passing those 3 months of paradoxical reaction, then we can start suspecting a suspected drug resistance, but certainly not an MRI done at 6 weeks, 8 weeks, 12 weeks. No, certainly not. And I'm sure you have asked this question to make, bring this question into discussion. Yeah.
Not really, but yes, many of our patients actually keep on asking, when should I come back? And what time this thing. So I think it is important, because this thing was not clear in my mind as to when would you label a patient who is not really improving. When would you start labeling him, or when would you start thinking in that line?
But I never get an MRI before 6 months, if at all, because MRI is inflammation, and in the initial treatment, just by treatment, good treatment response, inflammation is going to increase.
Yes. But patient is going to symptomatically improve.
Symptomatically better.
Sir, एक और question है इसमें. Patient has got junctional TB, probably 2 or 3 vertebral involvement, and you think that this patient might land up with a deformity which should not happen to this patient. When would you advise surgical treatment for this patient?
I think honestly, Amit, the response to treatment to even the paraplegic patient has improved, outcome has improved over the year by addition of instrumentation. So I personally believe that if at all kyphus is likely to increase, then these should be taken in early stage, because then it is easier and simpler.
तो सर शुरू कर देंगे सीधे पहले करेक्शन से और ATT उसके बाद देंगे.
अगर मेरे पास 60 डिग्री का काइफोसिस का आता है बच्चा या पेशेंट, तो मैं तो I take it straight way to surgery as well as start ATT and take it for surgery.
हाँ, उससे एक एडवांटेज है, you get tissue also for this.
But अगर वो 15 डिग्री का है, then I will not do it.
But if his kyphosis is increasing 15 के बाद 2 महीने बाद वो 30 degrees हो गई.
So if the kyphus is definitely increasing, and if I notice that there are 4 body disease, 5 body disease, and the patient already has 30-40 degree kyphosis, so better you intervene, because initial vertebral body loss, 1.5 initial vertebral body loss will give rise to a kyphosis of 50 degree plus minus 10. So agar aapka an initial vertebral body loss, one calculates by anterior body height. So if you take the cluster of 5 body segment, 5 body disease, and you measure the height, and you take suppose 2 centimeter to healthy vertebrae above and healthy vertebrae below, will give a mean. So if it is, so you can calculate that how many vertebral body is lost.
Thank you, sir.
Correction of the kyphosis is easier when the disease is active, as compared to when it has healed.
Yeah, absolutely.
As that is the time, then one should. And another problem when you're operating in the paraplegia of late onset, severe kyphosis with the salient. And if you remove it, if you do the surgery at that stage, there could be chances of avascular necrosis of the, or avascularity of the cord. any experience, Dr. Jain? Have you ever had it?
No, absolutely. You have really put the right thing. See, my experience of operating late onset paraplegia, I think it may not be more than 10, 12 patients. And the removal of internal salient is really a challenge. However, with now burrs, now the burrs are available, then maybe it will be little easier. But in the time when we were operating without burrs, it is a challenge. And inadvertent handling of the spinal cord while removing the apex of the internal salient is very, because that internal salient sometimes attached to the dura, adhered, not only adhered, almost it has stuck to the dura. It doesn't come out. So what the best would be that you don't remove the last part of the internal salient. You just hollow the bone, and then in the last you just break that. And sometimes you will not be able to break. And if you might have appreciated in one of the CT, that there is some flakes of bone are there in the canal. Yeah. Probably that was the part of bone which was attached to the dura, and we couldn't remove. But here the objective is to prevent further insult to the cord and not to get a recovery. So if patient understands, and I'm sure, I think we have exchanged quite a few patients where patient and we are talking to it is a challenge, no doubt. And I think this Look has written that extrapleural approach is better than transthoracic.
Yeah, certainly.
Sir, in one of your slides, you show that there was some epidural collection, but the spine was stable. So should we wait in such patient with drugs only, or we decompress these patients? Because as we read said, the cause of paraplegia or spinal cord injury sometimes is vasculitis. So, is it so, sir?
I think let me put it. How many patients in my life I have seen where after adequate surgery they continued on paraplegia or they worsened on paraplegia? See, what you are talking about, thrombosis of or endarteries of interspinal arteries. Yes, that is what it's very uncommon, very rare. This is an explanation to the rare cases who fail to recover. But it is not that common, and that pus is not going to precipitate that. And so that is why now more or less consensus that if spine is stable, there is only body disease and not the posterior complex disease as well. And it's not a very, so if spine is stable and there is only liquid interspinal content, then forget about it, it will recover.
Can we use steroid?
I have never given steroid in my life on any of the spinal TB cases. Never.
Any other question by the faculty, sir? Puneet, sir? Amit, sir, you are asking something?
No, I'm
Saraf, sir?
No questions now.
Puneet, sir? You are muted, sir. Puneet, sir, you are muted. Puneet, sir. Puneet Gupta, sir, you are muted.
Yes.
Yes, sir.
Sir, like nowadays we have more of the trend towards the surgical treatment. Like in cases of tibia, we most of the time, even in undisplaced fractures, we operate them so that we can mobilize these patients early. So does the tuberculosis spine, if we fix the patients early, can we mobilize them early? Does that has advantage or not?
Well, I have never used this advantage, but well, if one does, then I think this question is sometimes my students ask, and I'm sure Dr. Saraf and Amit also must be facing that students come with an article where showing that tibia, closed fracture tibia, fixed with nail, and the patient is mobilized 7.2 days and we are mobilizing at 2 months and 1.5 months. But my simple answer is that if the risk of complication in isolated closed tibia is some percentage, then I would rather wait for 1 month more and 2 months more to mobilize than putting a nail and mobilizing. Because if 5% of the patients develop infection, then for those 5 patients, it is going to be a big issue. And we get some of these. So my explanation is always that. And when I have 10 patients always waiting for surgery, then just to mobilize, I never do, because even I believe in ambulant chemotherapy. So even as such, after some time, I'm going to mobilize them with braces, suitable braces. So I believe in ambulant chemotherapy. And I would love the Saraf Sahab and Amit say something on this issue.
Sir, in spine, even if you immobilize these patients, they will somehow develop some of the deformity. But if we fix them early, we will even prevent that deformity also, or even the late complications of this deformity.
Which deformity we are talking?
So, like if we treat them conservatively, yes, this is a tuberculosis is a medical disease. We can treat the tuberculosis, but definitely there will be some kyphosis or there will be some deformity that may develop. But if we fix it early, we'll prevent that deformity also.
Even there is no guarantee that fixing early will not allow it to develop into deformity, 1. And 2, we are now adding some healthy segment, some normal segment, which we, if we are treating conservatively a stable spine, then we may be ending up in 3 segment or 2 segment disease segment. But if you immobilize taking purchase from the healthy segment, so then it means we are adding some healthy segment also to the disease area, immobilized area. So I think it is, to my mind, these kind of decision in surgical branches will continue to be debated. But I mean, I can answer what I do, and but certainly for mobilizing early, I would never do it.
Right, sir. Thank you.
Sirohi sir, should we end up the meeting here? Any other questions from the panelists?
Sir, I think enough has been discussed. Should we wind up now, sir?
Yes, sir, I think so.
Your choice.
I think everything has been discussed from diagnosis to medical and surgical treatment. So thank you very much, Dr. Anil. I would request our Honorary Secretary to give a formal vote of thanks to our panelists and the speakers and the audience. Dr. Puneet.
Thank you, Anil sir. It was a really wonderful and eye-opener webinar of this evening. It was very good academic. And I would like to thanks to you on behalf of Uttarakhand Orthopaedic Association. Dr. Saraf sir, thank you. Dr. Amit sir, thank you. Thank you, Dr. Sir. Thank you, Sirohi sir. Thank you, Ortho TV team. And thank you, all delegates. Thank you, sir. Have a good night.
Thank you.
सबको नमस्कार, सबको नमस्कार.
Namaskar, sir. सभी लोग.
Thank you. You became wiser now.
Lot wiser. Thank you, sir.
Thank you very much.